Good morning, everyone. I'm Dr. Madubela. As Dr. Hira has said, in our obstetric article, we are looking at a more selective versus a standard risk stratified heparin-based obstetric thromboprophylaxis protocol. This article was published on the Journal of American Medical Association in June 2024. So, venous thromboembolism, which may include DVT and PE, is estimated to occur in 1 to 2 per 1,000 deliveries. Pregnancy and postpartum patients have 4 to 5-fold risk of VTE compared to non-pregnant counterparts. VTE has been responsible for 9% to 10% of maternal mortality over the past 2 decades, thus contributing significantly to maternal morbidity and mortality. Risk particularly elevated within the first week postpartum. The changes in pregnancy that might contribute to the higher risk includes the hypercoagulable state, the compression of inferior vena cava and pelvic veins by the gravid uterus, and the overall decreased motility of a pregnant patient. Certain pregnancy complications and comorbidities further increase the risk of VTE, including the cesarean section, especially if complicated by infection, hypertension in pregnancy, cardiac disease, SLE, obesity, sickle cell disease, and multiple gestation. American Colleges of Obstetricians and Gynecologists, Society of Maternal and Fetal Medicine, RCOG, and the American Colleges of Chest Physicians, they recommend using these risk factors in a risk stratified approach to guide the appropriate utilization of postpartum chemoprophylaxis. In 2016, the University of Alabama at Birmingham, UAB, adopted a risk-stratified protocol for administration of heparin-based thromboprophylaxis in obstetric patients in response to the ACOG District Safe Motherhood Initiative, which is from now on is referred to in this article is referred to as the original protocol. Prior to the implementation of this protocol, Clexane was used at discretion of patient's physician, and in this article, it's referred to as the low anticoagulation guidelines prior to 2016. Who at all in 2020 reported that adaptation of the risk stratified protocol was associated with a twofold increased odds of wound hematomas, as well as increased risk of unplanned surgical procedures and blood transfusions without a significant risk decrease in VTE. In response to these findings, they developed a more selective approach to postpartum thromboprophylaxis administration. This analysis aims to compare the frequency of postpartum bleeding complications and VTE between the original protocol and the more selective protocol. So this table just shows the differences, the main differences between the original protocol from 2016 and the more selective protocol that came later after 2020. So we can see there on the original protocol, they included the low or high risk thrombophilia with family history, which is not in the selective, which is not in the more selective protocol. And they also needed 2 or more risk factors of the below conditions, which may be hysterectomy, endometritis, age above 40 years, preeclampsia with severe features, and thrombophilia. And then on the more selective protocol, they now need 3 or more risk factors, which may be hysterectomy, endometritis, or wound infection, pre-pregnancy BMI of more equal to 40, and higher order multiple gestation. So the methods, this study was approved by the UAB International Review Board. It was a retrospective observational study analyzing outcomes in patients who delivered between 1 January 2016 to 31 December 2018, which is in the period of 2 years, and between 1 December 2021 to 31 May 2023. All patients who delivered at UAB during both time frames were included in the analysis. Patients receiving antepartum anticoagulations were excluded. In 2019 and 2020, these years were not included. Sorry. So 2019 and 2020 were not included because the clinicians were starting to restrict the use of clexane based on the preliminary results from Liu et al. And the new protocols were not yet formalized at that time. The institutional postpartum order set, which is initiated after delivery, requires a review of patients' risk factors for VTE, and implementation has been used at the UAB previously with 95% compliance. Patients meeting the criteria for clexane have it initiated from day one, no sooner than 6 hours following NPD or 12 hours following a seizure, and continued until discharge. So this is a study table showing a study disposition of patients. So there was 17,846 patients who delivered at a study institution during these 2 periods. 357 were excluded because of the use of outpatient or antepartum anticoagulation, and then they were left with 17,489 patients. And then 12,430 delivered during the original protocol, which is from 2016 to 2018, and then 5,059 delivered during the more selective protocol from 2021 to 2023. 1,936 received anticoagulation in the original protocol, and 10,494 did not receive anticoagulation. On the more selective protocol, 427 received anticoagulation and 4,632 did not receive anticoagulation. And then when they analyzed the outcomes on the original protocol, they had 0.7% of wound hematomas, and they had 0.1% of patients that had VTE. And then on the more selective protocol, they had 0.3% of patients who had wound hematomas, which is like half of the original protocol group. And then they had 0.1% as well of patients that had VTE. So the outcomes that they looked at, primary outcomes, they looked at the clinical diagnosis of wound hematoma up to 6 weeks postpartum. This could either be a deep or superficial wound hematoma, or it could also be from a seizure wound or an episiotomy. There were no changes in recommended postpartum wound care, follow-up or routine evaluation during the study period. The secondary outcomes that they looked at were the new postpartum VTE that is diagnosed after delivery through 6 weeks postpartum. They also looked at the time from delivery to the VTE diagnosis, and they also looked at the safety outcomes that included wound complications, unplanned procedures, clinical estimated blood loss at delivery, transfusion of any blood product, or change in HP. So in terms of the statistical analysis, the differences in baseline characteristics, primary outcomes, and secondary outcomes were compared between the groups using the chi-square test of association or Fisher-Exact test for categorical variables, and t-test or Wilkinson rank sum test for continuous variables as appropriate. Multivariable logistic regression models were used to estimate the adjusted odd ratios with 95% confidence intervals. They also compared outcomes with the more selective protocol and the historical cohorts without anticoagulation guidelines, the one prior to 2016. They evaluated primary and secondary outcomes in patients who received anticoagulation in the more selective group and the original group, which is the focus of the study. Based on the group sizes of 12,430 in the original protocol and 5,059 in the more selective protocol, and the two-sided alpha level of 0.05, they calculated 80% power to detect a 50% reduction in wound hematoma from 0.7%, as mentioned, to 0.35 in the more selective protocol. All primary analyses were performed using a SAS version 9.4 and a significance level p-value of less than 0.05, with no adjustment for multiple comparison or imputation for missing data. Now, when it comes to results, out of the 17,489 patients that are included in the study, 71%, which is 12,400, delivered during the original protocol period, and 5,059, which is 29%, delivered during a more selective protocol. 350, which is 2% of the patients, were excluded due to antepartum anticoagulation use. Patients in the more selective protocol were seen to be older, had a higher BMI, they were more likely to use aspirin and more likely to be diagnosed with preeclampsia. Fewer patients were given Clexane in the more selective protocol groups as expected. The selective protocol was associated with a reduced rate of wound hematoma, driven largely by 50% lower rate of superficial wound hematoma. The more selective protocol was also associated with fewer wound complications of any kind. Compared with the original protocol, the more selective protocol did not differ significantly in the rate of VTE. There were no significant differences in other secondary outcomes that included unplanned procedures, estimated blood loss, use of uterotonic medication. In stratified analysis, patients who underwent cesarean delivery during the more selective protocol had significantly lower odds of any wound hematoma compared to those in the original protocol period. Wound hematomas among patients who delivered vaginally were not significantly different in these two groups. There were no significant differences in VTE diagnosis among those who underwent cesarean delivery or vaginal delivery. So just a summary of the results is in patients who received anticoagulation, they observed a significantly decreased risk of any wound hematoma in the more selective group from 2021 compared with the original group with no evidence of increased VTE. So this is the table explaining the results as we've discussed. I've just highlighted the two main things that they did look at, which is the wound hematomas. We can see 0.7% in the original group and 0.3% in the more selective group. And the diagnosis of VTE, you can see the 0.0014% and 0.008% that they said was not stated. They did not increase the less use of Clexane did not significantly increase the diagnosis of VTE. So while the benefits of postpartum prophylaxis for patients at high risk of VTE are clear, the safety of broad use of risk-based prophylaxis in lower risk population has been called into question. In a study done by Ferris et al., implementation of an institutional practice guideline for post-operative thromboprophylaxis in 2,059 patients undergoing cesarean delivery found a significantly higher rate of wound separation in patients receiving prophylaxis with no significant change with no significant change in VTE between patients receiving versus patients that were not receiving prophylactic anticoagulation. A more recent article by Kotaska additionally challenged the recommendation of increased use of postpartum chemoprophylaxis. The authors concluded that although postpartum prophylaxis is warranted in patients in high risk of developing VTE, clinicians should exercise caution in low risk population due to lack of data regarding benefits versus potential harm. The retrospective cohort study by Liu et al. Evaluated a risk-based approach to postpartum prophylaxis and found a 15-fold increase in anticoagulation use, a greater than 2-fold increase in wound hematomas, and no significant decrease in postpartum VTE in patients who received postpartum taxane. Liu et al. Recommended continued evaluation and reconsideration of current thromboprophylaxis guidelines given the demonstrated harm. Given the rarity of VTE, which would necessitate a large randomized trial that is likely infeasible, future studies should continue to evaluate prophylaxis guidelines to determine the utility and safety of routine use of heparin-based thromboprophylaxis, even in population at higher risk of postpartum VTE. In addition, future studies should evaluate the safety of newer oral anticoagulants in the postpartum period, considering lactation as potential alternative to heparin-based thromboprophylaxis. So the strength of the study was that there was a large patient population that was used. There were no institutional changes in clinical wound evaluation and management. Primary and safety outcomes were abstracted using individual chart reviews, which minimize the risk of misclassification. Demographically, socioeconomically, and they use a diverse population. The limitations were that its retrospective nature, they were unable to evaluate causality and fully address confounding factors. The setting was at a referral center with a high rate of obesity, diabetes, chronic hypertension. So it's the population that is already at risk of having wound complications. Also, it was a single institution study, so generalizability may have been missed. Also, the patients might have also presented in their local hospitals, maybe with some other wound complications that might have been missed. So to conclude this study, a more selective risk stratified approach to taxane thromboprophylaxis protocol for VTE was associated with decreased rate of wound hematomas without increased risk of postpartum VTE. So we need to always make sure we weigh the risk and benefits before we can use the taxane. Also, we also need to note that pregnancy alone without these risk factors, you can actually have DVT. So we need to always continuously individualize and risk stratify patients.
Thank you, Dr. Maluleka. Well done. Any questions from the live audience first? I can't see the online people. Any questions?
Hi, Bhavna.
Hi, Prof.
Good morning, Dr. Hira and the team. Yeah, thanks. The journal articles Grace was on off sick. Yes. Yeah, I was saying that apologies, the journal articles were not sent because Grace was off sick. I think, yeah. Anyway, I think this article, you know, it's well written. That's one thing, and they have inflated the numbers in that they've included the whole population that delivered, and not well. At some point, they focused on those with risk factors. I would have expected them to hone in on the risk factors they excluded in the more selective group. You know, the more than 40 years, the severe preeclampsia. They should have told us somewhere in that group that developed the VTEs, how many of those patients had the risk factors excluded in the selective group. So are they now saying that those risk factors do not bear much weight? Or, you know, because obviously the results are clear that there is more benefit in dropping those. I think there's about 2 or 3 of them. Something should have been said regarding the onset of VTE in a group that was historically considered high risk, thrombophilia, severe preeclampsia, high BMI, and I think, no, they didn't drop high BMI, they dropped advanced maternal age. Because it's important for us to say, well, do we pay more attention? Does it carry more weight or less weight than we thought, and so forth? Yeah, thanks.
Thanks, Prof. No real comment from our side. Any other hands up?
Yeah, I don't know whether I got lost with the discussion. When the discussion started with the article, I didn't hear them discussing their results. I heard them discussing what other people have found. Normally, when you start your discussion, you discuss your own results and contrast them with what other people have found, whether I missed that or not, because when you started the discussion, you started and quoted somebody, another study that did something else, and you went on, but I didn't hear any discussion of their results, because they're supposed to discuss their results and then contrast them with what other people have found. Did I miss that, or is that how the discussion started?
So we'll just go back to that slide, Dr. Maise.
So they discussed their results here, but during the discussion, yeah, they did quote Faras et al. And Kutaska.
That's what I'm saying. When you start a discussion, you discuss your results. I mean, the results that they're giving us, the results, you give us the results. This is what I found. Then you come to the discussion, now you discuss your results and you contrast them with what other people have found. You know, so I heard Professor, this is a well-written story about what is well-written here when the discussion does not discuss the results. The results are mentioned in the results section, which everybody does, and you mention your results, but you don't discuss them. You say, this is what I found. Then you come to the discussion, discuss why you found it that way. Is it consistent with what other people have found, or does it differ? Why does it differ? That's what the discussion is all about. So I was just wondering, why did they, what is happening with this discussion? But anyway, I mean, obviously it doesn't detract from what they found. I just found the way the discussion unfolded was a little bit unusual for me when I follow the usual way that the discussion normally unfold.
Sure. Dr. Maise, I take your point, and I think we need to emphasize learning points more than whatever. So your point you are saying is how registrars should focus on their discussion. We should be focusing on how do they do. So first paragraph, as you rightly say, should summarize the results without repeating them. So you summarize the message from your take away points from your findings. That's the first paragraph of your discussion. Then you follow it paragraph by paragraph with teasing out each of your main findings, trying to explain them in the context of what others have found. And if your findings were any different from what others found, you then try and find other literature that can support or contradict. And you explain why you think there was a difference in your results. Then your last paragraph is then you'll get your conclusions and recommendations. That's how discussions should be factored. Obviously, I focused on the bigger numbers and whatnot, and then what I was expecting in the content. But basically, that's the message you write. And I think in the last 2 weeks, I distributed through the registrars the format of your discussion. If your reg reps haven't sent it to you or you haven't checked the WhatsApp, I may send you a summary recently. Thanks, Barbara.
Thank you.
Thanks, Prof. Thanks, Dr. Maise, for those comments. Any other hands up? No. If not, thank you, Dr. Maluleka. We're going to go on to the gynae article. Dr. Gamede.
Good morning, everyone. As Dr. Hiram said, I'm Dr. Gamede, and I will be presenting the second journal. It's a gynae study. So this was a retrospective cohort study that was done in the United States, and they were looking at the outcome after early pregnancy loss management with mifepristone plus misoprostol versus misoprostol alone. And this study was published in the Journal of American Medical Association Network, recently published on the 8th of October 2024. The introduction of the study, early pregnancy loss or miscarriage is the most common complication of early pregnancy and affects more than 1 million people in the US each year. Early pregnancy loss is defined as a non-variable intrauterine pregnancy at less than 13 weeks of gestation. Treatment option for patients experiencing early pregnancy loss includes expectant management, medical management, as well as procedural management, like uterine aspiration. For patients who are hemodynamically stable, all three options are typically reasonable, and management should be guided using shared decision-making with the patient. Medical management of early pregnancy loss typically include the administration of misoprostol with or without pre-treatment with mifepristone. Combination treatment with mifepristone plus misoprostol has been shown in clinical trials to be more effective than misoprostol alone for early pregnancy loss management. In a randomized clinical trial, the addition of mifepristone and it has shown to increase the efficacy of medication management from 75% to 91%. Despite updated guidelines from the American College of Obstetrics and Gynecology in 2019, mifepristone remains underutilized for patients with early pregnancy loss. So the objective of this study was to describe the different clinical outcome after early pregnancy loss management with mifepristone plus misoprostol versus misoprostol alone using the commercial claim data. As I've mentioned, this was a retrospective cohort study of patient individual who experienced early pregnancy loss in the United States. The study period was between the 1st of October 2015 and the 31st of December 2022. And they were using the National Insurance Claims data from the IBM Method Scheme Research Database. So the participants of this study were pregnant women between the age of 15 to 49 that presented with an initial early pregnancy loss diagnosis, and they only included those with those who having private insurance. Including an exclusion criteria, they included pregnant women between the age of 15 to 49, patients with evidence of medical management defined as having a claim for misoprostol with or without mifepristone in the 7 days after an index early pregnancy loss diagnosis without evidence of uterine aspiration procedure or procedure during that same time period. And they excluded patient with a diagnosis of ectopic pregnancy, molar pregnancy, induced abortion, stillbirth, and as well as patient with recent early pregnancy loss management within 56 days, either with medication or uterine aspiration. Their statistical analysis, a background analysis was conducted to explore association between demographic characteristics and medication management type using the chi-square test for categorical variable and t-test for continuous variable. They also use the background analysis to investigate association between the type of management and the outcome and complications of the two managements. And a p-value of less than 0.05 was considered statistically significant. So in their study, they selected a total number of, they identified a total number of 332,984 with early pregnancy diagnosis between the age of 15 to 49. So from those patients, they excluded 292,030 due to lack of evidence of medical management. So they were left with 40,954 patients. So in those patients, they further excluded 8,977 patients, of which 1,243 they had a diagnosis of induced abortion, 856 had ectopic or molar pregnancy, 1,041 stillbirth, 8,118 they had recent medical management, and 13 recent uterine aspiration. So the total number of patients that were included in this study were 1,977. So from those patients, 975 patients, they were found to be treated with mifepristone plus misoprostol, and 31,002 they were treated with only misoprostol. So looking at the results of the study, as we've said, that the total number of patients that were identified were 1,977, and they received medical management. The mean age of all these patients was 32.7, and when looking at the diagnosis that they found that majority of these patients had a diagnosis of a missed abortion, about 72.3%, and 26.9% had a diagnosis of a spontaneous abortion, and 0.8 had both diagnosis code. In this study, also look at where the patient were getting their services. So, and they find out that a majority of these patients were receiving their initial diagnosis of early pregnancy loss in the outpatient clinic. About 83.3% they were diagnosed in the outpatient clinic, and about 10.7 patients they were seen or diagnosed in the emergency department. So in this study, and what they've also noted is the use of mifepristone plus misoprostol. So they found out that a lot of patients were receiving misoprostol alone as compared to mifepristone plus misoprostol. About 97% of the patients they were receiving misoprostol, and 3% they only received both regimen. They also found out that the proportion of individuals who received mifepristone plus misoprostol was increasing over the years as the study started in 2015 up until 2022. So in 2015, was used higher when the index presentation was occurring as, in the outpatient as compared to the emergency settings. So it was about 3.4% versus 0.9% with a p-value of less than 0.001, which was statistically significant. Which means the mifepristone was mostly used in those patients in outpatient as compared to the emergency department. Misoprostol only management was associated with increased incident of subsequent procedural management, about 14% versus 10.5% with a p-value of 0.02, which was statistically significant. And also it was also found that it was related with increased emergency department visits as well, with 0.79% versus 3.5% with a p-value of less than 0.01%, which was also statistically significant. So this table basically is the summary of the study and the patient characteristics they were using. We can see the total number of patients there, and they were comparing it with the patient who used mifepristone plus misoprostol and those that would use misoprostol alone. So the first criteria that they looked was the mean age. Out of all the patients, the mean age of those patients that they involved in the study was 32.7. And those that used both Murphy and misoprostol, the mean age was 33.8, and those that used misoprostol was 32.6. And then they look at the years encountered from 2015 of the study to 2022. So what we're seeing here is that the use of misoprostol only was more as compared to mifepristone plus misoprostol. And also what we're noting is that the use of mifepristone was increasing over the years. From 2015, you can see the total number of patients that were included in 2015, it was 1,053, and the only patient that used both regimens, there were only 7. So over the years, the use of misoprostol was gradually increasing. And they look at the geographic region as well, and also we can see or note that the use of misoprostol was more as compared to the both regimen of mifepristone and misoprostol, with a p-value of less than 0.01, which was statistically significant. They also looked at the areas, whether it was an urban area or rural areas, and we can note that in the study, a lot of patients that were included were from the urban areas. And as well, the misoprostol was used more as compared to both regimen. But we can also note that in the urban areas, they were using the mifepristone, the both regimen, mifepristone and misoprostol, more as compared to the rural areas. So, and the location of service as well, as we can see, the diagnosis was made more in outpatient, in the outpatient clinic as compared to the emergency department. And also the misoprostol was used more in like between those these two studies. And what is significant as well here is that the use of mifepristone was more utilized in the outpatient department as compared to the emergency department. And they also look at the insurance coverage, whether it was a primary holder or a spouse or a dependent as well. So when you're looking at the outcomes and the complications that they got between the management of these two groups, so what was more significantly was that those patients that use only misoprostol had subsequent procedural management as compared to those who use both mifepristone and misoprostol, with a p-value of 0.02, which was statistically significant. And the other value was the subsequent emergency department visit that was statistically significant, that those that use only misoprostol, they were prone to have subsequent visit in the emergency unit as compared to those that were given both mifepristone and misoprostol. And then they also look at the complications that they were getting in both groups, such as hemorrhage requiring blood transfusion, actually embolization, all those complications. What we noticed that there were not a lot of complications, but almost all of these complications were being seen in those patients that were using misoprostol. So in discussion, patients who received misoprostol alone were most likely to receive subsequent procedural management and to have subsequent visits to the emergency department. Although mifepristone use increases significantly throughout the study period, it remains subsequently underutilized. The rate of mifepristone use was statistically significantly low when the index diagnosis of early pregnancy loss occurred in the emergency department. So the limitation of the study was the accuracy of the early pregnancy diagnosis and the procedural code, as well as the data claim that were intended for, they were intended for billing purposes. So the billing codes were, they found out they may not incomplete or they were incorrect, all that. And due to the nature of the claims data, they didn't know whether, like, which facilities had the mifepristone. Maybe they're not using the mifepristone because they didn't have it or not, so they didn't have that information. They couldn't also accurately determine the specific gestational durations, exact dosing, as well as the route of mifepristone administration and the time from mifepristone to misoprostol usage. And the study was only based on a large convenient sample of privately insured individuals. So in conclusion, mifepristone is underutilized for medical management of early pregnancy loss, but its use is associated with lower need for subsequent uterine aspiration and decrease in the number of subsequent visits to an emergency department. And increase in access to mifepristone for early pregnancy management may decrease health care utilization and expenditures. Thank you.
Thanks, Dr. Kamede. I just want to add, the Department of Health has obviously been encouraging the use of the combination because there's a new circular, well, not new, it came out on the 29th of August, that they're now providing a combination pack of mifepristone 200 milligrams with 4 tablets of misoprostol. So it's 5 tablets in total, 1 Mifi, 4 miso, sorry, I get a bit tongue-tied with the Mifi and miso, so I'm going to call it mifepristone and cytotec. So 1 mifepristone and 4 cytotec tablets, that's 342 Rand, whereas the original pack contained 3 mifepristone tablets, and that was 828. So just the cost difference, I don't think it's really a difference because the one had 3 mifepristone tablets and this one has 1 mifepristone tablet. And you're getting 4 cytotec with it, but they're encouraging the combination use rather than cytotec alone. And that's been available for a while now. We have used it in Mahatma Gandhi, although it ran out for a bit and now it's back. So the original pack had 3 mifepristone tablets and the new one is a combination pack. I don't know if the other hospitals have been informed. Any questions firstly from our audience? Dr. Mason?
Just from my point of ignorance,
Sure.
there is obviously a early pregnancy loss or early fetal demise, which we used to call it Mr. Bosch. We still use the term that's in the museum, Mr. Bosch,
Sure.
which is not supposed to be used anymore.
Yes.
Vis-a-vis incomplete miscarriage, because I had 26% of the cohort was incomplete versus the biggest proportion was obviously a early fetal demise. So with the incomplete, are we saying the same issue that we need a combination for the incomplete, or is the combination more effective in the early fetal demise? That's that. I just want clarity from my point of view. What does the evidence show?
What are they comparing, Dr. Maisa? Are you saying?
No, I say in this cohort, they had both groups. They had those that had the early fetal demise. In other words,
therefore requiring a TOP.
Yeah, requiring obviously.
As an indication for termination.
Yes.
It was early fetal demise.
Early fetal demise.
Others were?
Incomplete miscarriage.
Am I getting that? So these are not people who were requiring TOP?
No.
So it was people with an ICA?
Yes. Is that not correct?
Yes,
that's what this cohort is all about.
Okay, so it's not like it's an out. You see,
it's patient that came to the outpatient with and were diagnosed to have an early fetal demise or incomplete, right?
Yeah.
So initially in the earlier years, people were giving all those patients only cytotec.
Yeah. In
the latter years, they were now giving them a combination of those, and then they were looking at the cost-benefit ratio, how many patients come back, how many complete evacuation based on the sort.
Because for me, just on that indication for the study, we are comparing things that are not the same. With an early fetal demise, the miscarriage has not started. You are now initiating. And now we need actually to have just focused on that group alone and look at MISO versus MISO plus MIFI, right? So that is one group. Now here you're comparing a group that has not started to miscarry with a group where the miscarriage is already in process. And we want now to compare and what have you, So you should really have, and their outcomes were what?
It's more effective to use the combination rather than the
so they should have spoke, even if they put them together at some point, they should have just said, in this group alone, I initiate the process myself with this versus that, and in a group where I am adding on, because with the ICA, you are adding on, you are trying to see how much can I clear the uterus now of what has remained. So already for me, that's a big problem in the study. They are comparing things that are not the same, apart from all the other things that they're talking about.
They did mention the limitation, Prof. This is from the insurance company, and they looked at how many people claimed.
Yeah,
for
you
the
see, you can
medication,
already see
so-
that it's not even a clinician who's writing the story.
Yeah, so it's half
They
of
lack
the,
that insight. You know, some studies are written by Med Shield and Discovery Health. That person is just crushing numbers. This is crushing numbers, you can see. It's not a clinician, he has no insight as to what should I be comparing.
I don't think they were trying to compare, they were just saying in a cohort. So my question was, in the usual kind of evidence that we have, do we need a combination for a patient with an incomplete? Or the combination is mainly required for a patient who have not started bleeding?
That's my point.
That's what I'm trying to.
We are saying the same thing.
Yeah.
That
So
had
they-
they told us about that we didn't get that.
so they didn't separate the two, that's what we're saying, that they didn't separate the two.
Yeah, no, so when I started, I said, I'm asking for a point of ignorance because I have not kept myself abreast from the audience. In the patient with the incomplete, is there evidence showing that a combination is superior to a patient who already started bleeding? Is the combination necessary or just not in your study now? I'm asking in
What are
general.
we doing? Yeah.
In general, in a patient who already started bleeding, do you need a combination of or misoprostol alone is adequate just to squeeze whatever is in the uterus? Because the antiprogesterone does a certain job in a patient who's not started bleeding. So I just wanted to know from the registers who have been kept abreast, is the evidence strong that in a patient who's already bleeding, you need both, or both is superior to just one? That's what I wanted to understand.
And also, what is the current practice? Do you evacuate them? Do you MVA them? Or do you just, how many of your patients, obviously we are not there ourselves, we are there. How many of your patients do you say, I will definitely use cytotec here to evacuate a combination, or are we MVAing them where it exists, or we send them to follow the theater list and plug and you know, crowd the theater queues? What are we doing on the ground? Anyone dares to?
There's a hand there.
For incomplete, they have to fulfill specific criteria. You can't just manage everyone medical.
Those medical, yeah.
They have to strictly fulfill those criteria.
Are the
Otherwise, you have
registrars
to
doing that? Let's
They
hear.
are not, they are not.
Let's hear Dr.
They are
Adila,
doing
she's
medical
worked at
management
CANS
ways,
and
it's
she's
not,
worked at Ushieni.
appropriate.
What have you been doing, Dr.?
So I was actually going to comment with regards to the latest FIGO 2023 guideline under incomplete doesn't list mifepristone. And the 2023 FIGO that they released was more emphasizing on using misoprostol and mifepristone
Say it
for all
again.
different ones. So the 2023 FIGO guideline that they
Yeah.
came out with has emphasis on using mifepristone and misoprostol in
For
all their,
ICAs.
no, for all their categories. The
Okay.
previous guideline in 2017, the FIGO guideline was just concentrating on misoprostol only. So they introduced mifepristone to a lot of their categories in the 2023.
So
guideline.
basically what we are doing.
Yes,
right.
what we should be doing.
Yeah.
If you look at if I'm not mistaken, the incomplete miscarriage categories for all the trimesters doesn't include mifepristone.
So if you have an early ICA,
It still just said misoprostol.
just miso and
Yeah,
not a
it didn't have
combination,
the combination. Yeah,
according to FIGO.
that was the 2023 one. Yeah.
What are we doing? Are registrars confident enough to be doing medical management? Is it happening anywhere? Or all our patients are being MVA'd and evacuated in theater?
Registrars like misoprostol. Yes.
So they do give it in early pregnancy. Do you follow up your patients or you don't know what happens to them? Because I mean, studies for us to run studies like this, we have to have the advantage of they can tell you how many patients return. Or we just hope and pray to God that you call them back.
Yes.
And you document.
Yeah.
Okay.
So you know, that's what I just wanted, because it's a good platform for this article here to say, first of all, what does the evidence say before you start to, a guideline is based on research that's already been performed, then you use the published information to write down a guideline. So FIGO is not doing a research, They are taking whatever has been published and have the guideline. So that's why I started off by saying, registrars, what does the evidence say? In a patient who already started bleeding, do you need mifepristone? Because mifepristone, if you look at why it's being used, is obviously to create a certain environment where the bleeding will eventually okay. That's what the role of mifepristone antiprogesterone is. And once that happens, then the cytotech will then allow the uterus to contract to squeeze out the stone. So that's why I was asking, what does the evidence say? The one that FIGO used or whoever used to write down a guideline. Does it say a patient's already bleeding still requires mifepristone or not? Does the evidence show that in terms of the story? So I hear FIGO does not include the mifepristone in the patient who's already bleeding. They include in the patient who's not bleeding yet, which is the early fetal demise, or the patient that you're trying to do a termination of pregnancy who's still got a fetus who's alive. So you use the mifepristone to obviously, so to speak, for lack of a better term, to trigger that initial whatever the story is, so that you can then whatever the story is. So I'm hearing this.
Let's see your results again.
These insurance people now, I don't know whether they are part of the pharmaceutical trying to encourage using mifepristone, even in the 26% that obviously had already started bleeding. That's why I asked the question in terms of the story. So I think that's what we just needed as a register to be clear that the patient is already bleeding. I can't really see what the mifepristone does in the patient, but I can see in the patient who is not bleeding, whether the fetus is alive or dead, that the mifepristone will add value. But I just wanted clarity from those that are perusing the literature whether it makes a difference or not. Because now you're saying, Bhavna, for our current recommendation from our DOH is that we must use a combination in the patient who already bleeding.
No.
Yeah, you know.
She said
They're just saying that this is the new pack available and they've
for
removed,
TOP.
it doesn't specify,
doesn't
I'll
say
read
TOP.
it for you. Doesn't specify.
That's what you.
So TOP.
Is it for TOP?
For
Yes,
medical
that's
TOP,
what
yes.
Oh, for TOP.
Right, so
Okay.
that's what the Department of Health is saying, so I'm just informing you that that's
Oh,
what's
for
available
TOP.
at the moment.
Okay.
Right,
Okay.
for TOP,
Not
but
for
I just
incomplete.
went back to their first slide, so they just quote one randomized control trial
Okay.
where the addition of mifepristone increases the efficacy of medication
In what?
medical management from 75% to 91%.
In what category?
But they don't say, so medication management, that's all they mention. That's from their one study that they quoted.
Okay.
And from our figures here, from the results, they said the majority of the patients, 72% had a diagnosis of missed abortion, which is our blighted ovum
Yes.
or an embryonic pregnancy. 26% had a diagnosis of spontaneous abortion. So the vast majority had a missed, meaning they hadn't started aborting yet. And 0.8% had both diagnostic codes, meaning they weren't sure about the diagnosis. I'm just guessing, like Prof says, it's not a clinician writing the article. So the majority of the patients had not started aborting yet,
Yes.
which is probably why the outcomes appear better in the mifepristone group.
In actual fact, I don't know where you find the ICA from, because as you are saying, 72%.
26% is ICU.
It's in 26.9% had a diagnosis of spontaneous abortion, meaning that it's an
Okay.
ICA. Or they'd already
Oh, okay.
started. They started
ICA
aborting.
or complete.
Okay, let's see the results.
Yeah, that's what I've
Not
got.
those, the ones on
Okay.
the table in terms of how many patients ended up evacuating, how many
Okay,
needed.
1 second. This is how they divided it up.
Not that one, the next one. The next results, yeah, that one. So it's the one that tells you how many needed procedural management, like they had to come back.
Yes.
And then the other one that said how many had endometrial, what was that? Subsequent.
So the first one is subsequent procedures. The next one is subsequent medication. So they needed more medication. Then it's inpatient hospitalization, subsequent ED visits, subsequent outpatient clinic visits. They're not saying why they came back. Complications, hemorrhage, uterine artery embolization, other surgical management.
So Bhavna, I'm
just
interested in
complications.
that group, the first line, which is
Yeah.
subsequent procedural management as well as subsequent ED,
Okay.
meaning emergency visits.
Yeah.
And you can see that the combination was less.
Yes.
Now, they have sufficient numbers, 72% was the list, so not where abortion had already started.
Yes.
They could have just focused on that 72% so that we can really see the effect, or else maybe also they divide and tell us that 26% where we are saying the process has already started. Is there any way? Now they clumped everybody together.
Fortunately, the authors don't know what we're looking for, so
Yeah,
they've
that's
just
what I'm trying to
combined
say.
everything
Yeah.
together.
Just as an addition, obviously, we're using this also for to just refine our management as well. When the patient, obviously, this patient that we are saying, Valencia and all that, but obviously early pregnancy losses, they come to us, we think they are incomplete, and then we decide, oh, they are suitable for medical management, which for us is misoprostol. I hear some says we call them back. Do we have to call all of them back after giving them misoprostol, or you say to them, if you continue bleeding beyond a certain point, then you come back? What does the figure say? Does it say everybody must be called back? Because I'm hearing when prophets asking, do you call them back? Do you document? And it sounds like we're saying all of them must come back, which is one of the things that the funders are trying to reduce, this recall back, because it comes at a cost to come back and what have you not. And we don't pay attention to the fact that the patient needs taxi fare to come back. In terms of that, she has already presented. In the past, we'll just evacuate her, she's gone home, she doesn't come back. Now, if we give a medical and you say everybody has to come back, then the cost is increased. The question I'm asking, and I'm asking under a correction here. I doubt that the figure says everybody must be called back, and I doubt that obviously it says if the patient continues bleeding beyond a certain time frame, they must come back. Is that correct or incorrect? Is that my understanding correct or incorrect? It's correct.
10 days, if they continue bleeding heavily, they should return. And if they stop bleeding, they do a home pregnancy test in a month. So a month after treatment. And if that remains positive, they return for follow-up. But I know in practice, we don't do that. We generally bring everyone back and do a scan to see that the uterus is empty, but the guidelines don't say everyone has to come back.
Yeah, so the reason I was just emphasizing that is that if we are trying to adopt a certain way of managing patient, we also must ensure that it doesn't unnecessarily disadvantage the patient in terms of cost and everything else. Because if the evidence worldwide shows that if the patient fulfill the criteria for medical evacuation, which is what we are doing, and the success rate is that high, then not everybody must come back in terms of that. Only a certain subcategory of those patients must come back, and we must have that within our guidelines in terms of that.
Thanks, Dr. Maisa. I think we have to look at cost versus safety as well. So if you told her not to come back and she assumes everything's fine, but she's developed sepsis 10 days later, it's a question of patients being aware. And I think that's why we call them back. So in Mahatma Gandhi, we are using medical management quite a bit because theatre is always occupied with cesarean sections and we can't do too many evacs. So where they qualify, they get medical management and they come back a week or 2 weeks later for a rescan. It's more to ensure patient safety. Yes, you're adding to the cost, but we have seen patients go to GPs for TOPs and come back completely bled out in hypovolemic shock 2 weeks later because nobody told them to come back.
The GPs, their fault is that they don't tell the patient when you start bleeding, or these are the time frames, or these are the landmarks that you must follow, right? That's when the GPs go wrong. And I always say for those GPs that affect us, all you need to tell the patient when she starts bleeding, and this is that, go to the nearest facility, whatever the story is in terms of that. But if the patient has now come to us and we say she's got an incomplete, she fulfilled medical treatment because she's less than 12 weeks or she's 12 weeks, whatever the story is, there is the tablets, you might then say to her, you'll come back if 1, 2, 3 happens. And that's what the guideline actually says, come back if 1, 2, 3. If you recall everybody back, then obviously that defeats the purpose actually of the medical treatment, because they could have just had an evacuation or manual vacuum when they arrived. They wouldn't have had to come back. although I know the limitation of that. So I'm just saying we also just need to have the courage of our conviction in the way we are practicing to say, do 1, 2, 3, come back if 1, 2, 3. Yes, 1 or 2 of them might not come back, whatever the story is. So then the other question that we'll ask, just like did an audit, is to say, those that we sent home and then came back, when they did come back, how many of them, when we did a scan, did we find that they actually require additional intervention? If we then do that audit and find that almost all of them don't require anything, then you are confident enough to say, I don't need to keep continuing to do this story that I'm doing in terms of that. And secondly, obviously, ultrasound that we're using to say we need to do something. If you look at the evidence to tell you, is there cutoff above which in terms of the measurement that you of endometrial thickness that you should be given something, it's not very clear as to whether there is a cutoff that's really sensitive enough to tell you above this, you should say it's not, or if you see a mixed echogenicity, it's easy. But if you just see endometrial thickness, and I see many of our registrars in the room 6 room, they just see endometrial thickness. And they say, no, the patient is not complete. And I say, well, who told you that? I mean, endometrial thickness does not say if you just see endometrial thickness of more than this. It doesn't say that. That's what everybody studied. So again, we are not putting that into our management of the patient. So yes, I'm just saying, if we are going to be using medical, let's ensure that the patient do benefit from it and not be disadvantaged from it. I mean, King Edward, fortunately, we got both evacuation and medical. So the medical ones are usually those ones. So no, we don't need theater. Just take the treatment and what you know. But as to whether they all do bring call back, I don't think they do call back all of them. As long as we give them 1, 2, 3. If this and this happens, come back. If this and this doesn't happen, you don't have to come back.
Thanks, Dr. Maisa. Prof, before I take your question, just to clarify that endometrial thickness from our registrars that are reading, what cutoff did they provide? I've seen 1.5 centimeters, I've seen 1.8. Any new information from our registrars as your cutoff for endometrial thickness before we call it complete? No, nothing in FIGO, WHO? Okay.
Yeah, I just wanted to add, because I think everyone was emphasizing at the callback, it's ultrasound assessment for complete miscarriage, which I think, and we already highlighted that ET is a problem. And if you look at the TOP guidelines, I think it's even the I forgot what it's called now, but it's not the local one. There's an international TOP guidelines regarding medical management, and your assessment of complete is actually more clinical rather than ultrasound. So I think if you're in doubt, yes, ultrasound, but if it's clear she's come back, OSCE is closed and symptomatic, symptoms have resolved, and prick test is negative, you can manage as a complete. But I think trying to use an ET, you're going to either overtreat patients, and we are seeing more and more Ashermans around, and it's really challenging to treat, and it's also quite disheartening when it's your first miscarriage and you had an evac and now you amenorrhea. So so I think just be cautious of over-treating.
Thank you for that, Prof. You had a hand up?
No, it's just a reminder I posted on the group, the December closing or end of the year party on the 7th, and also that next week the provincial health has embarked on a widespread activation of cervical cancer screening, marking the 17th of November, which is the 90-70-90 strategy. So make sure that all your, especially at HCUs, just check with your nurses, just make sure that they are aware of such a campaign, that every woman in every hospital clinic who qualifies by criteria should be screened. And also on the form, don't just write cytology, because the forms have not been adapted. Please say plus HPV, because if you don't add the level, just make sure that you say plus HPV weights. You're supposed to take cytology and just add HPV. And please, for all HCUs, make sure that the processes are in place. They've got enough speculums, whether it's possible or not. So it's just basically increasing awareness, because they had planned to launch, but they failed, like a massive campaign. So that's the best we can do.
Sorry, Prof, are you saying we must round off the nurses and the doctors who are qualified for Pap smear and
Everybody,
is that what you're saying?
everyone in your hospital,
Yeah,
whether
yeah,
you are a health worker, a cleaner, a kitchen worker, everybody in the premises next week
Yeah.
who has never had a smear, it includes me.
Yeah, that's what I'm asking.
Yeah, if I qualify.
Yeah, no, you do qualify.
I don't.
Sorry, just to thank Dr. Maluleka and Dr. Gamede, time's up. Thank everyone for their attendance.
And all the wives of the people of the
Thanks everyone.
all the wives of the